but initially just to confirm that
When is Katkade, sir?
Katkade is
Katkade, sir.
inducing. I called him sometime back, so he's inducing. But anyways,
One of my oldest friends. So right from Singhania days.
okay. Manisha, are you there?
We just heard her, like
Sorry.
2 minutes back, she said something. 2 minutes back, she said that it's not possible to send the reminder mail.
Uh,
Hello, madam. YouTube is now active.
okay, okay. पण आता ते मीटिंगच लॉग इन करतील ना, मीटिंग मध्ये लॉग इन करतील ना.
येस,
तर
कुठं
तेव्हा
नाही केलं तरी मॅडम त्यांना मीटिंग मध्ये जॉईन करता येईल.
अच्छा, पण बोलता नाही येतील ना तिकडून.
युट्यूब वरून नाही बोलता येणार, त्यांना फक्त
करेक्ट,
झूम वरूनच बोलता येईल.
करेक्ट. ठीक आहे. Manisha, are you there? Shall we start now? Once, okay.
Parna, Dr.
Yeah,
Katkade will be joining late, yeah?
yeah. I just spoke to sir. He's inducing a case. So,
Okay, fine.
now once Manisha has joined in, we can start.
Yeah. Okay. I think there are two people. Dr. Meenal also is not able to join.
Yeah, and Dr. Manohar Bharne is also saying that no email yet. Mm. Actually, now everybody is thinking that there's some Zoom ID. So they can log in from there.
Dr. Katkade is joining, right? No?
He may be late. It's okay. We
Yeah.
can start. I just
Hi, Shamini.
Hello. Hi. Good to see you here.
Oh, thanks to you.
Hello, Gunjotika sir.
Hello.
Hello. Hi, Shamini. Hi,
Hi.
Mrunalini. Hi, ma'am.
Hi, Mrunalini. Hi, Ashwini. You can unmute yourself.
Hello.
Hello.
Sir. Yes.
Good evening.
Good evening.
Nice to see everyone.
Hello.
Hi, Atul Ashwini. Hello.
Hi,
Hello.
Ashwini.
Hello.
Hello.
Parna, should we start?
yeah. I was waiting for you only. You there?
Yeah, I got logged out by mistake, so I just logged in again.
Okay. Switch on your camera, no?
Yeah.
Yeah. Okay, we'll start then. Start. Good evening, all. On behalf of Thane ISA, I welcome all of you to yet another interesting webinar on updates in urological topics and procedures. I thank all of you for the overwhelming response. We have 126 registration for today's webinar. It's really heartening. On behalf of Thane ISA, I welcome our today's chairperson, Dr. Sunil Katkade sir. Sir will be joining us shortly. He's inducing a case and he's the founder member and past president of Thane ISA. Currently, he's the CEO of Solaris Hospital, Thane. I admire Sir for his innovative ideas and his problem-solving capabilities. I take this opportunity to invite our today's moderator, Dr. Mrunalini Vani. She has fellowship in regional anesthesia and pediatric anesthesia and is a freelancer anesthesiologist in Thane and Mulund area. I now welcome our president, Thane ISA, Dr. Manisha Ghosh, and our treasurer, Thane ISA, Dr. Nilima Kelkar, for further proceedings.
Thank you, Parna. It gives me great pleasure to welcome all of you here today for this excellent webinar that we are going to have. I'm very happy to welcome Dr. Varsha Vyas, ma'am, who is the MMC observer for today's webinar. She is very familiar and dear to all of us at Thane Anesthesia Society, as she has been an MMC observer for many of our CMEs. A very dedicated academician, madam is currently the professor of anesthesiology at MGM Vashi. It also happens to be her birthday today, and on behalf of Thane Anesthesia Society and everybody over here, madam, a very happy birthday to you and a life full of love, happiness, and good health.
Thank
So
you so much.
when we were just chatting yesterday and I was telling madam about the webinar, she mentioned how close she felt to our branch, especially to Dr. Katkade sir, who had anesthetized her mother for a major surgery.
Yeah,
so welcome,
exactly.
madam.
Thank you.
So I also take this opportunity to remind all of you that the Society of Anesthesiologists Maharashtra State is having its annual election from 18th July to 21st of July. It is not only our right but also our duty to vote, and all of us must vote actively for a robust SAM's new executive committee. Without further delay, I request the chairperson, Dr. Katkade, he'll be joining us, but our moderator, Dr. Brunalini, to proceed with the scientific program. Dr.
Hello,
Mrunalini,
everyone.
over to you.
Yes,
Yeah.
hi. Yes, thank you, ma'am. Hello, everyone. So we'll start now. Obstructive uropathy is one of the most urgent clinical entities that both urologists and nephrologists have to diagnose. So our first speaker has an experience of over 4 decades in neurosurgery. He completed his MBBS and MS from Nair and MCH neurosurgery from JJ. He has also cleared DNB general surgery and DNB urology exams. He is attached to various hospitals in Thane, namely Jupiter, Bethany, and Kaushalya, including his own hospital located near Talaupali. He also works as a visiting consultant at Ajit Scanning Center, Kalyan, and Century Rayon Hospital, Shahar. Over to you, Dr. Atul, sir. Sir?
Thank
Hello?
you. Thank you, Dr. Monali, for the nice introduction. Good
Thank you,
evening,
sir.
everybody. Greetings to all the anesthetists on behalf of all the urologists. Today, we shall be talking about surgical management of urolithiasis and taking a brief overview of this. Urolithiasis is one of the commonest problems in urology which are seen. This is one of the commonest problems. Almost 20 to 30% of all cases in urology OPD are of urolithiasis. Not all the patients require surgical management. Only about 30% of these cases require surgical intervention. Rest are managed quite well with medical treatment or oral hydrotherapy also. These patients present typically with pain, which is usually a classical renal colic from the flank to groin with vomiting. Few patients do present with urinary complaints like frequent urination, burning urination, hematuria. Few of them do present with fever, sepsis. Nowadays, we see quite a lot of asymptomatic patients also. These patients are detected to have urolithiasis while they undergo some investigation from some other problems, or many times for health checkup. which is becoming more and more popular. Now, when we talk about management of the urolithiasis, the lot of depends on classification of calculi. So let us consider this classification of calculi. This calculi can be classified as per the site or position and as per composition. As per site, this calculi can be renal calculi, which can be callaceal, or pelvic or stagon, which may be a partial stagon or a complete stagon. Partial stagon is a calculus which occupies renal pelvis and one or two calyces of the major calyces of the kidney. The complete stagon calculus is one which occupies all the three calyces, major calyces of the kidney and the pelvis. Then we have ureteric calculi, which can be upper ureteric, mid ureteric, or lower ureteric. Then we have bladder calculi, which may be multiple or single, and we have urethral calculi. The management differs for each site of the calculus. Then this calculi can be classified as per the composition. The composition of the stone or the calculus decides the hardness of the stone, and that determines the time taken to fragment the stone. Most of the urinary calculi are made up of calcium oxalate. These are very hard stones. Out of these calcium oxalate stones, they can be calcium oxalate monohydrate or calcium oxalate dihydrate. Calcium oxalate monohydrate stones are the hardest stones, and they are very difficult to fragment them even with various lithotripsy methods. The calcium oxalate dihydrate stones are little softer, but they are still hard stones. The next commonest composition of the stone is uric acid stone. These constitute about 10 to 15% of the all calculi, and these calculi are seen with patients with high raised uric acid levels and those patients who have a acidic urine. Then calcium phosphate. This contributes to about 5% of the patients with calculus disease. These are little softer stones. They have a lot of phosphates in them, calcium phosphate. They are made up of calcium phosphate. These form in a stagnant urine. So these are seen in urinary bladder, and this can be fragmented very fast and rapidly. Then we have struoid stones. These stones have magnesium deposits also in them, and these are associated with infection. So these are commonly seen in the renal pelvis stones. Then we have other types of stones. These are very rare to see, less than 1% of the stone. These may be xanthine or cystine calculi. Now, let us come to surgical management of the urolithiasis. Surgical management of urolithiasis is acute management and definitive management. Usually in acute management, the patient presents with severe colic, or patient can present with infection, signs suggestive of pyelonephritis, sometimes pyonephrosis, and these patients do have an obstructive uropathy also. The management of the acute management of urolithiasis is double J stenting. We put a double J stent, and these patients improve quite rapidly. And this procedure can be done. This is a very challenging situation. The patients have got quite a lot of other complications also, and these are the really challenging cases. But once we put in a DJ stent, the pain factor goes down, the infection settles down, and the patient improves quite fast. Once the patient is settled down, or in patients who don't have too much of acute symptoms, we go ahead with definitive management. Definitive management consists of ESWL, that is extracorporeal shock wave lithotripsy, then cystoscopy. Cystoscopy for urethral and bladder calculi. Then comes URS, that is ureterorhinoscopy for the urethral stones, which can be semi-rigid or flexible ureteroscopy. Then PCNL, that is percutaneous nephrolithotomy, which can be a standard procedure, or if when you use a smaller size scope, it can be a mini perc or mini PCNL. Now, the next modality is RIRS, that is retrograde intrarenal surgery. This is a new modality which has come in, and here we can tackle the renal stones with flexible scopes. And lastly, ECIRS, that is endoscopic combined intrarenal surgery, where PCNL or more precisely mini PCNL and RIRS has combined together to tackle the complex renal calculi. Extracorporeal shock wave lithotripsy or ESWL. This is a non-invasive procedure where there are shock waves are produced outside the body in the machine with the help of electrohydraulic or electromagnetic source, and these shock waves are focused onto the stone. The machine comes in contact with our body, and these shock waves are focused onto the stone, so that this calculus gets fragmented, and these fragments are subsequently passed down the urinary tract. This procedure is usually done in supine position. The shock wave generation is mainly by two things, electrohydraulic and electromagnetic. Out of this, electromagnetic gives lesser pain as compared to electrohydraulic. The pain factor is mainly at the site of contact where the waves enter into our body. So whenever we are using electromagnetic source, usually anesthesia requirements are not there. Patient usually does not require any analgesic also. But whereas if we are using electrohydraulic source, then at the point of contact, patient do experience some sort of a pain, and patient do require some sort of analgesia, sedation, or very rarely anesthesia also. This procedure is done obviously in general anesthesia in children. This procedure was quite popular about 15 to 20 years back and was the main modality of treatment. But now it has taken little backseat. That is mainly because two things. This procedure has got unpredictable results and can take little longer time for the clearance of the stone also. Secondly, many times additional procedures are also required for the clearance of the stone. With the advent of newer technologies like mini PCNL, where the scope size has become smaller, and RIRS, this procedure has really taken a back seat, and now we hardly do it in less than say about 1% or 2% of cases. In most of the places, this treatment has become obsolete also. Now we come to cystoscopy. Cystoscopy is doing anything in the urethra and bladder to remove the stones. This is mainly for urethral stones. Urethral stones are usually small stones, and they are mainly impacted. Sometimes they are impacted in the urethra. We put in a cystoscope inside, catch these stones with the help of forceps, and take them back out. If the stone is slightly bigger and cannot be manipulated from the curvature of the urethra, we push them back into the bladder, break them with lithotripter, and take out all the fragments. Bladder calculi also, if they are small and multiple, we can either pick up with the forceps, or we can give a bladder wash, flush them out, like how we remove the TURP prostatic chips. Or if the stone is bigger, then we do a lithotripsy, pneumatic or laser, break the stone, fragment the stone into smaller pieces, and then take those pieces out. Sometimes the stone is very big and very hard. Then we do a suprapubic puncture cystolithotreaty. In this, we put in a small needle suprapubically into the bladder, put in a guide wire, dilate the tract, and put in a larger size cystoscope or a nephroscope, break the stone, and then take out these fragments. This prevents any urethral injury because of the larger size of the scope is passed suprapubically and not perurethral. So the damage to the urethra is not there, and the stone fragmentation can be done little faster also. Now we come to ureterorhinoscopy. Ureterorhinoscopy, as I mentioned earlier, is of two types: semi-rigid, which is done for lower ureteric and mid ureterics, and sometimes for upper ureteric, and flexible ureteroscopy, which is mainly done for the upper ureteric calculi. Here, what we do is we put in a cystoscope, pass in a guide wire. Usually, if we are able to bypass the stone and place the guide wire into the pelvic callaceal system, we are the most happiest persons on the earth. And then we put in a ureteroscope, and then once we visualize the stone, then we start fragmenting the stone. This fragmentation can be done with a pneumatic lithotripsy or laser lithotripsy. The pneumatic lithotripsy is uses a principle of jackhammer, works on a jackhammer principle, where impact is created with the help of compressed air or compressed gases, most commonly oxygen, which is easily available in all the world. This impact is transmitted by the probe onto the stone, and then the stone gets fragmented because of the repeated hammering of the probe. The importance of this and the beauty of this lithotripsy is that even if it touches the mucosa or the soft tissues, it does not cause any damage to the tissues at all. But if any hard substance comes, like if you keep it over the bone or something, then it can fracture the bone also. That is the only problem with this. But other problem faced with is because of this impact, it gives impact to the stone. So many times what happens is when we give the impact, the stone just flies away into the proximal dilated pelvic callaceal system, and then we have to chase that stone also. Then another method is a laser lithotripsy. This is a new modality which has come up. Here we use lasers to fragment a stone. Laser fiber is brought in contact with the calculus, and laser is fired. This causes little thermal energy is produced at the contact, and the laser stone gets fragmented or powdered. This is better for the harder stones, as there is no impact to the stone doesn't get migrated and it remains in the same place. Only thing is, because of the heat generation there, it can cause little thermal injury to the mucosa surrounding, or if we touch this laser to soft tissues, it can definitely cause tissue damage also. When we break a hard stone with these lasers, we get a feeling of कभी कभी लगता है अपन भी भगवान है. We get that sort of feeling when we break a hard stone like calcium oxalate monohydrate with these lasers. This procedure is usually done in lithotomy position. Here, most important thing is we have to manipulate the scope quite frequently and to quite a lot of extent. So we require a working space in the patient's thighs so that scope can be manipulated easily. Now we come to PCNL or percutaneous nephrolithotomy. This is of two types, standard and mini per. Standard PCNL uses the larger size scope, usually more than 22 French. Most commonly 24 or 26 French size scopes are used. And this is useful for large size calculi, hard stones, which can be broken easily. Then we have mini per or mini PCNL, where the scope size is less than 18 French, and we can manage this mini pers with for the smaller stones. The procedure involves, initially we do a cystoscopy in lithotomy position, put in a ureteric catheter, place it in the pelvic callaceal system, then fix it to the perurethral Foley's catheter, make the patient prone, and start with the PCNL procedure. PCNL procedure basically consists of getting a puncture and entry into the pelvic callaceal system after we opacify the system under fluoroscopy, or using a sonography guidance, we make a puncture and get an access to this pelvic callaceal system. The puncture is very important here. We have two types of punctures. One is subcostal and other is supracostal. As you can see here, the subcostal puncture is below the 12th rib. From here, we can access mostly the inferior callaces and middle callaces. But if the kidney is quite mobile, we can access upper callaces also. Second, other type of puncture is supracostal puncture. When we go above the ribs, sometimes we have go above the 12th rib, sometimes above the 11th rib, and very rarely above the 10th rib to gain access to the pelvic callaceal system. Which approach to be used is determined mainly by position of the kidney, position of the stone, and anatomy of the calyces, from where we can get maximum clearance of the stone. So if we are using a supracostal approach, we have to be very careful about injury to the pleura and the lungs. Once we get a puncture and urine starts coming out from the initial puncture needle, we pass in a guide wire, which is placed in the pelvic calyces system, or in the preferably in the down into the ureter, and then we dilate this tract, put pass in a nephroscope. When we see the stone or the calculus, we start fragmenting with pneumatic lithotripter or a laser do a laser lithotripsy. These fragments are taken out either intact or with we make it a powder and then take it out. After the procedure, usually a nephrostomy tube is also placed. Mini perk is basically the same procedure we do it, but only difference is as we are using a smaller size of scope, we have a smaller incision, we require a less amount of dilatation. This causes reduction in pain factor, both intraoperatively as well as postoperatively. Normally, the tract size is very small, so we don't put tubes unless there is a complication or there is infection, then only these tubes are put. Since there is a not, most of the times tubes are not put, patient also recovers much faster and in a better way. Patients are very comfortable after this mini PCNL or mini perk procedure. So nowadays, we have started doing PCNL in supine position also. This is a newer technique which we have adapted. And only thing is, this is technically more challenging. Here, patient is placed in a supine position with a slightly lateral tilt, and a puncture is taken behind the posterior axillary line, and the tract is dilated. Rest of the procedure remains the same. Only concern about during this procedure is risk of colonic injury. Since the patient is supine, the colon tends to fall down over the kidney, and there are chances of colonic injuries in this procedure. But otherwise, this procedure is getting little bit of becoming little popular, where a prone position is to be avoided and can be done easily if you have a expertise. Then we come to RIRS, that is retrograde intrarenal surgery. This is used to tackle the upper ureteric or pelvic calyceal calculi. Some pelvic calyceal pathologies like tumors or strictures can also be tackled with this. Here, we pass a flexible ureterinoscope retrograde from the urethra, and then obviously this requires flexible instruments like lasers, baskets, and forceps to tackle the calculi. Flexible ureteroscope has a broad advantage of its tip being flexible in 360 degrees. So we can access all the calyces, see small stones also, which are there in minor calyces also, and this can be tackled very easily. Since this procedure is done under vision, it has got more predictable results, and patients also do return to daily routine earlier. This procedure is done in a lithotomy position. A low lithotomy position is preferred so as to keep the ureter straight. Here, initially, we do a cystoscopy. Usually, these patients are pre-stented to make easy passage of the access sheath, which is required for the RIRS. We take out the DJ stent, put in a guide wire, place it into the pelvic calyceal system, and then over this guide wire, we pass in an access sheath which goes up the ureter, and it is placed near in the pelvis or just below the stone if we are tackling the ureteric calculus. Then through the access sheath, the flexible scope is passed, and when we reach up the kidney, we can see all nice calyces, and we can see the calculus also. Once the calculus is seen, we can fragment that. Now, here I would like to draw your attention to the movement of the stone. This is because of the respiration. See how much movement is there. With each respiration, the kidney moves up and down, and so does the calyces and the calculi. And when we start doing laser lithotripsy, the stone gets fragmented or powder. Here we have two types of lasers, holmium and thulium fiber laser. Holmium laser is used mainly to fragment the stone. It produces small fragments of the stones, whereas thulium fiber laser literally powders the stone. The stone just melts away as we proceed with the procedure. And once the fragmentation is done, we flush out all those fragments from the access sheets. The access sheet is very important in this procedure. There are the passage of access sheet. Access sheet is usually a little larger, 10 French size. So preferably a pre-stented ureter which dilates, then the access sheet, this ureter accepts access sheet easily. Sometimes we have access sheets with a suction side channel where we can attach a suction also and suck out the irrigating fluid and keep the intrarenal pressure so. Another challenge during RIRS is the intrarenal pressure. Here, proper irrigating fluid pressure has to be there for two things. One, for better visualization. And secondly, when we are using laser, the temperatures have to be kept lower down. So the irrigation fluid has to go on simultaneously. Secondly, the proper drainage has to be there so that the intrarenal pressures don't rise too much. That is the reason these access sheet with suction attachment are becoming more and more popular. Sometimes we do RIRS without access sheet also, but that causes little problems in drainage of the irrigating fluids. Now, when the intrarenal pressures increase, they open up the pylolymphatic channels and the irrigating fluid starts flowing away from through the pelvic LHL system. This causes these fluids get accumulated in the below the capsule. This causes stretching of the capsule and does give rise to pain also. When the irrigating fluids goes into the third space, it produces bacteremia, and this can produce shivering and hypotension. And later on, patient can land up with sepsis also. So it is very important to keep the intrarenal pressures very low during intrarenal surgery. Now coming to challenges, another challenge in the RIRS is movement of the kidney. With each respiration, kidney keeps on moving up and down, and it becomes difficult for us to fragment the stone by pointing or getting the contact of the stone with the laser fiber. So we prefer to have no movement at all, where we can fragment the stone very nicely, or there should be a minimal movement during fragmentation so that we can synchronize our laser firing along with the movement of the respiration and fragment the stone. There is now a new approach is coming, combined approach. This is called as endoscopic combined intrarenal surgery, or ECIRS. This is usually done for the complex renal stones where there are few stones which are there in the different calyces, and by PCNL they may require multiple punctures, maybe 2, maybe 3, for the total clearance of the stone. Here what we do is we usually do a mini perk and fragment the stones, and then do a RIRS from the per urethral and go to the inaccessible calyces which cannot be accessed by PCNL. We access them with the help of RIRS and bring the stones in the pelvis and fragment them. Usually this is done with two teams of surgeons. One team operating from the flank doing mini PCNL, and another team operating from the per urethral doing RIRS. But the two surgical teams may be there, but anesthesia team is the only one and managing two surgeries at a time. This procedure is done in this point of a position, modified lithotomy position with slight lateral tilt. This gives a good clearance rate to this good clearance rate. I think we have covered most of the procedures quite well. Thank you so much. We are because you are there. Thank you.
Thank you, sir. Very comprehensive lecture, sir. I especially like the part where you use the meme from Sacred Games.
Thank you.
So there are no questions in the chat box, but I had a small question for you. So when you're doing an RIS procedure and there is you find an incidental ureteric stricture, so how do you usually proceed? Do you put a DJ stent or you do convert to a mini perc or PCNL?
Yes, that's a good question. If we are encountering a ureteric stricture, we usually put a DJ stent because that is the thing which is going to dilate the ureter. Sometimes we, if the stricture is there, we dilate with the dilators, keep a ureteric stent for a little longer time, maybe 3 weeks, 4 weeks. Then when the ureter is dilated, we take out the stent, pass in the access sheath and do it. Or if the stone is in the upper ureter or near the pelvis where which can be accessed from PCNL, we can convert that procedure to PCNL also. But
Okay.
that is very rarely we do that. Most of the time,
Okay.
yeah, most of the times we do like to do procedures per urethral only rather than giving a small, even though puncture is small, we don't like to give a puncture.
Yes. Okay. Thank you, sir.
Thank
So
you.
thank you so much, sir. There are no other questions. Okay, so we'll move on to the next session. The multisystem pathology associated with renal disease can have profound effects on anesthesia. So, anesthetists must know how to assess these patients, when to investigate further, and how to treat common complications. Sharing her experience in managing such complicated patients day in and day out is the very talented Dr. Ashwini Mukashi. She completed her MBBS and MD from KIMS Karad and has worked as a lecturer in
Urolith. Hello.
Yes, ma'am, we can hear you.
Okay. Just a minute. Thank you, Mrunalini, for this kind introduction. So now, after this elaborate talk by Dr. Atul about the surgical management of urolithiasis, let us carry this knowledge into the world of anesthesiology. I will be talking about the anesthetic techniques for removal of calculi at different sites in the renal system, followed by a few interesting case scenarios. Starting from the urethral calculi can be easily removed by giving short general anesthesia. And here we can give pre-medication of injection midazolam 0.02 milligram per kg, fentanyl 1 microgram per kg. The induction is done with propofol 2 milligram per kg, and the maintenance is with top-up doses of propofol with oxygen, with nitrous oxide, isoflurane or sevoflurane, either by mask or by putting in an LMA or iGel. In cases where we want to avoid general anesthesia, the urethral calculi can be removed by giving saddle block with injection bupivacaine 1.5 cc. Coming to the bladder calculi, now here the choice of anesthesia depends on the size of the calculus. If the calculus is a pickup or a small calculus, then short general anesthesia, as I described before, can be given. But if the calculus is a large calculus or if there are multiple calculi, then spinal anesthesia is the anesthesia of choice. Here, the surgeon's approach may be either per urethral most of the times, or sometimes they may take a suprapubic approach. The level of anesthesia should be at least T8 to prevent the pain due to stretching of the urinary bladder wall. Anesthesia for ureterorhinoscopy. Ureterorhinoscopy is done to remove the calculi from the upper, middle, or lower ureter.
For the upper and middle ureteric calculi, spinal anesthesia is preferred, and here the level should be at least T5-6. If we plan to give general anesthesia to this patient, then utmost care should be taken that the patient should not move during the surgery, because when the semi-rigid scope is inside the ureter, it may cause injury to the ureter or it may cause damage to the scope. For lower ureteric calculi, when the calculus is at the UV junction, general anesthesia can easily be given, short general anesthesia, but otherwise we can give spinal anesthesia and the level should be T5-6. Anesthesia for percutaneous nephrolithotomy. Now the procedure of PCNL is mostly done in prone position, and general anesthesia is preferred because in this position, the patient remains very comfortable throughout the surgery. Now, there are two approaches for this PCNL. One is the supracostal approach, where the initial puncture needle passes above the T12 rib, and second is the subcostal approach, where the initial puncture needle passes below the T12 rib. In the supracostal approach, when the initial puncture needle passes, it passes very close to the pleura and the lungs. So care has to be taken that the injury should be prevented. So when we give general anesthesia, we should keep the patient in full expiration during the supracostal puncture, so that in expiration, the lungs and the pleura, they move away from the initial puncture needle, and hence the injury to the pleura and lungs can be prevented. In case of subcostal approach, we can give maximum inspiration so that the kidney is pushed down, and that becomes very easy for the surgeon to do the initial puncture and enter into the pelvic alveolar system. Care has to be taken in supracostal approach, and it is always better to auscultate the patient post-operatively or see the patient under fluoroscopy for any injury to the pleura. PCNL can also be done under spinal anesthesia, but sometimes the patient remains very uncomfortable in spinal anesthesia in prone position. Also, it sometimes so happens that when the major part of the calculus is removed out of the pelvic alveolar system, some small fragment goes and sits in some calculus, in some calyx. And what happens then is that towards the end of the surgery, when the spinal action of the spinal anesthesia is wearing off, the surgeon has to manipulate the scope and try to reach that fragment which is in some calyx. So this becomes very uncomfortable for the patient, and the patient can have pain. So when the calculi are big in size, then combined spinal epidural anesthesia should be given, or we can add adjuvants in spinal anesthesia. Anesthesia for retrograde intrarenal scopy. The procedure of retrograde intrarenal scopy is becoming very popular, and here a flexible scope is used to remove the calculus by laser fragmentation. Now, the main challenge for us here is the movement of the diaphragm and kidney with respiration. Because as the diaphragm and kidneys move with respiration, so does the calculus, which has to be fragmented. And hence, it becomes difficult for the surgeon to fragment a moving calculus. So what is preferred is general anesthesia, because here we can control the ventilation of the patient. Now, if we give general anesthesia to a patient and use normal ventilation, then the movement of the diaphragm up and down can cause the calculus also to move up and down, and that hinders the laser fragmentation. Also, it can cause injury to the mucosa of the kidneys. So many different types of ventilation are being tried to keep the calculus immobile. One such ventilation is the periodic ventilation, where we can give apnea up to 30 seconds, keeping a watch on the oxygen saturation and the end-tidal carbon dioxide of the patient. During the apnea period, when the calculus is immobile, the surgeon can do the laser fragmentation. But in this case, the chances of hypercapnia or the patient to desaturate is very high. So what we are using is low volume, rapid rate ventilation. And here what we are using is suppose for a 50 kg person, we are keeping the tidal volume at around 300 and a little rapid rate around 18 to 20. And this ventilation we are using only when the laser fragmentation is being done. And this we have to synchronize with the laser fragmentation as we can see on the screen in the operation theater. The most ideal ventilation which has been described is the combined respiratory support. And here the high frequency jet ventilation is combined with low volume mechanical ventilation. And this is described as the most ideal ventilation where the calculus remains immobile. But this is still in experimental level, and the high frequency jet ventilation is not very easily available everywhere. In patients who have cardiac or respiratory comorbidities, spinal anesthesia can be given in a patient of RIRS. But here our job starts much earlier. We have to counsel the patient that at times they may have to hold the breath during the laser fragmentation. So we train the patients in the wards to breath hold and also tell them to raise their hand or signal by raising the hand when they can no longer hold the breath, so that the surgeon and the anesthesiologist both know that they cannot hold the breath any longer and the laser fragmentation can be stopped. The advantage of spinal is that it is low cost. In some cases under spinal anesthesia, the patient may feel pain when the intrarenal pressures increase. And this can be an indication for us to take care that the intrarenal pressure is increasing. When the calculi are multiple or if it is a big calculus, then combined spinal epidural can be given. Also, we can add adjuvants to spinal anesthesia. Now, in the video which is being shown, I have used half cc, that is 25 microgram of injection fentanyl with bupivacaine for a patient of RIRS. Anesthesia for emergency urological cases. Now, there are some patients in whom they have obstructing calculi which do not respond to analgesics, or there may be obstructing calculi which increase the serum creatinine of the patient, or the patient may be having pyelonephritis or pyelonephrosis. So all these cases, they require DJ stenting to relieve the obstruction or to relieve the infection which is there. Amongst these cases, the patients with pyelonephritis or pyonephrosis, these patients, they are sometimes very toxic and they may have fever with chills, tachycardia, hypotension. And here special attention has to be given to all their parameters, their creatinine levels, their electrolytes, prothrombin time, ABG, bicarbonate levels, the hydration of the patient, the output of the patient. And hence this needs a multidisciplinary action. And here all these parameters have to be corrected and this patient needs DJ stenting. So such cases can be done under local anesthesia with sedation or local anesthesia with general anesthesia, or if the patient is very toxic, sometimes we have to do them only under local anesthesia. So in such cases, it is a teamwork mainly of the nephrologist, the urologist, and the anesthesiologist all working together and bringing the parameters of the patient to normal. And the improvement is very drastic once the patient is DJ stented, and with all the remaining supportive treatment what we are giving, the patient improves very fast. Positioning of the patient. Now, there are different positions for different procedures. So here for urology procedures where we are doing the removal of calculi, the main position is the lithotomy position, and prone position is given in case of PCNL. For the lithotomy position, we prefer the low lithotomy position. In high lithotomy position, what happens is there is a tilt in the pelvis, and because of that, the angle of the ureters change. So this is not what we want. So we have to keep the lithotomy, low lithotomy position, where the angle between the patient's trunk and thigh should be obtuse. There should be maximum abduction between the thighs to give a good space for the surgeon to operate. And the pressure on the nerves should be avoided by giving adequate padding. In high-risk patients or patients with comorbidities, legs can be strapped to prevent hypotension. Coming to the prone position for PCNL, if we are giving general anesthesia to this patient, then the patient should be intubated with flexometallic tube or Portex tube. Care has to be taken to avoid kinking of the Portex tube. You have to secure the endotracheal tube to prevent dislodgement. With the coordination of the entire OT staff, we have to make the patient prone. And while making the patient prone, the neck and the spine should be in one line. Rapid reinstitution of full monitoring should be done. Reassess the endotracheal tube position and the ventilation. The bolsters are placed lengthwise. In this case, that is, the bolster should be placed lengthwise from the axilla to the iliac crest, and the spine for PCNL should be straight. There should be no curve in the spine, and the horizontal bolsters are not preferred. The chest and the abdomen should be kept free for respiration. Airway should be accessible by turning the head to one side. We have to protect the forehead, the ears, the eyes, and the chin of the patient. The arms should be placed by the side of the trunk, and the angle between the trunk and the arm should not exceed 90 degrees to prevent the stretching of the brachial plexus. The breast in case of females and the male genitalia should be free of pressure, and provision should always be there to turn the patient to supine position in case of emergencies. Now, after discussing all these anesthesia techniques and the position, I would like to share a few cases. The first case which I would like to share is a 35-year-old male patient with pain in the right side of abdomen, fever, and vomiting since 2 days. The patient had tachycardia and a temperature of 103. His BP was 110/70. On investigation, his WBC count was 20,000, serum creatinine 5.3, electrolytes were normal, INR was normal, all other biochemical tests were normal. The CT KUB showed right upper urethric calculus with hydronephrosis with pyonephrosis. This patient was posted for cystoscopy with right DJ stenting. Now this stenting was done under local anesthesia combined with general anesthesia. Normally, when the serum creatinine of the patient is high, I like to give injection paracetamol with injection tramadol 1 cc IV half an hour before surgery. The pre-induction, induction midazolam and fentanyl is given. And for induction, we use titrated doses of propofol with oxygen and nitrous oxide by mask. Local instillation of 10 ml of 2% xylocaine jelly was done. And thus, combining this local anesthesia with general anesthesia, the stenting was done uneventfully. This patient who was DJ stented, after 3 weeks, he came for RIRS, and then his vitals were normal, his chest was clear, all his reports were normal, even his serum creatinine had come down to 1.3. And for RIS, we planned general anesthesia. So general anesthesia was given according to the normal protocol. That is given, we have given paracetamol with injection tramadol half an hour before surgery. Then pre-induction injection midazolam with injection fentanyl. And for induction, we have used propofol with scoline. After intubation, the patient was maintained on oxygen with nitrous oxide, with isoflurane and atrachuria. The main thing what we had to take care of here was the movement of the kidney and the calculus during laser fragmentation. So low volume rapid rate ventilation was used during the laser fragmentation, and this was synchronized with the laser fragmentation as it was seen on the screen. The second case which I would like to share is a 77-year-old female patient with history of fever with chills for 3-4 days, breathlessness for 1 day. She was a known case of hypertension with diabetes with COPD. Her pulse was 110, BP 110/60, temperature of 101, and her saturation on air was 90/91. On auscultation, she had bilateral rhonchi and bilateral Krebs and tachycardia. On investigation, her WBC count was 16,500. Her platelet count was low. It was 42,000. Her serum creatinine was 1.48. Her C-reactive protein was 292. INR was normal. Blood sugar was 250. On CT abdomen, she had a right pelviureteric junction calculus with right pyelonephritis with bilateral minimal pleural effusion. So this patient was posted for cystoscopy with right TJ stenting. Now this patient had to be stabilized before, and so oxygen supplementation was given, bronchodilators were started, diuretics were given, antibiotics were given, started, and the patient was given insulin according to the blood sugar level. One single donor platelet was given because her platelet count was 42,000. And the patient was stabilized, and once the platelet count was normal, this patient was posted for cystoscopy with DJ stenting under local anesthesia with sedation. So preoperative analgesics were given, IV paracetamol with injection tramadol 1 cc intravenously. The patient was explained that as her parameters are not normal, we will give her sedation only during the procedure. So the positioning, painting, draping was done before. Injection midazolam with injection fentanyl was given in titrated doses, and this was combined with local instillation of 10 cc of 2% xylocaine jelly. And the procedure was done uneventfully. Here, I would like to add that in female patients, as the urethra is short, it becomes very easy for us to do this DJ stenting in local with sedation. That is, the patient remains quite comfortable. We can also add oxygen, nitrous oxide, and sevoflurane by nasal cannula to make the patient a little calm. So, should spinal anesthesia be given? So I feel that spinal anesthesia is really not required for DJ stenting because DJ stenting is a very short procedure, and most of the times we can do it is done very fast. So it can be comfortably done with local anesthesia with sedation or local anesthesia with general anesthesia. So spinal anesthesia may not really be required. Now this patient, this female patient, she came for RIRS later, and because of her COPD, we decided to do the surgery under spinal anesthesia. So counseling of the patient was done. The chest physiotherapy was started in the ward, and the patient was taught to breath hold in the wards and also give a signal when she could no longer hold the breath, so that it became very comfortable for the surgeon during the procedure to do the laser fragmentation as the patient was already counseled before. The third case which I would like to share is a 69-year-old male patient with right renal calculus posted for right PCNL. The patient was obese and he had lordosis. He walked 4 to 5 kilometers daily with no history of breathlessness. He was a known case of diabetes with hypertension on treatment. His pre-anesthetic checkup was done in sitting position. His vitals were normal, his chest was clear, and his saturation on air was 97. His chest X-ray, ECG, 2D echocardiography, all were normal. Now, a big surprise awaited us because when this patient was taken on the OT table and made to lie supine and the monitors connected, his saturation was 90-91. So this was a surprise for us, and we really did not know the reason why his saturation was so less. So as this was an elective case, we decided to wait and reassess the patient because doing PCNL with a saturation of 90-91 was risky. So we did the CT chest of the patient. We repeated the 2D echocardiography. We did the ABG where his PO2 was 67 and PCO2 was 44. Opinion of cardiologist and chest physician were taken. Apart from the ABG report, there was nothing new which was found. And the chest physician said that he may be a candidate of obstructive sleep apnea. He started prophylactic bronchodilators with oxygen supplementation. On third day, the patient's saturation was 93-94 in supine position. The surgeon to change the plan from PCNL to RIRS so that the prone position can be avoided. And so we did this procedure of RIRS with combined spinal epidural with oxygen supplementation, and the procedure was uneventful. So with this, I end my talk and thank you everyone for patient listening.
Thank you, ma'am. You covered all the little details in the pathophysiology and management. So there are a couple of questions in the chat box that I would like to ask you. So Dr. Smita Rao has asked that about the role of thoracic segmental spinal anesthesia in PCNL.
Actually, segmental spinal anesthesia for PCNL, initially for PCNL, the cystoscopy is done and the guide wire is passed. So we need anesthesia for the lower part as well. So we cannot do PCNL only under segmental anesthesia.
So you would prefer the lumbar spinal anesthesia that we usually do. And Dr. Manisha Ghosh has asked, what was the tidal volume and respiratory rate was used in case 1 when the GA was given and during the laser fragmentation when you said that shallow breaths were given.
Yeah. That patient was around a 60 kg person. So we had kept it around 400, like say 6 milligram per 6 ml per kg and all. We can keep the tidal volume and a rate of around 18. But that is only for during the fragmentation. Otherwise, during the other procedure, we give a normal ventilatory rate and ventilation like volume.
Okay. So there are no other questions. I had just one small question of my own. So does your routine protocol include a post-operative chest X-ray for PCNL procedures?
Yes, especially when the supracostal approach is taken, we take a check X-ray after the surgery.
Okay. Okay. Thank you so much, ma'am.
Thank you so much.
Just a second, ma'am. Somebody else has asked only. Okay. I'm not understanding this question. Dr. Chandrasekhar Godbole has asked dexmedetomidine question mark. So maybe if he asks a complete question, then I can come back to it again.
I think
Do you use
as dexmedetomidine for procedural sedation? Is she using? I think that's what he means.
Acha, okay. So basically the dexket combination, the dexmedetomidine and ket. Huh?
Yeah,
He's asking, can we use dexmed for sedation? Dexmedetomidine.
Not use dexmed for sedation because I'm comfortable with midazolam and fentanyl. And sometimes with dexmed there is bradycardia also. So I prefer midazolam with fentanyl.
Agreed.
Okay, ma'am. Thank you.
I just had an experience to share.
Joined us. So
yes. Oh, okay. Hello, sir.
Hello.
Varna, sorry, please continue.
Yeah. Welcome, sir. And I wanted to wish Varsha Vyas Madam happy birthday. I just wanted to share an experience. So sometimes we receive these patients who have, say, very tight stone, which is causing severe obstruction. So I've witnessed two cases till now where once the stone was fragmented, immediately on extubation, the patient goes into urosepsis, and one of the patients had become tachycardic, and I had to uh, re-intubate the patient because patient was in severe urosepsis. We had to change the antibiotics, and it was diagnosed as urosepsis, and patient also needed NORAD infusion. So, yeah, I wanted to share this.
Very true. This is all because the intrarenal pressures were high during the procedure. So
Yes.
basically, we need to bring down the intrarenal pressure. So what we do
Yes.
usually in such cases, we put in a DJ stent, wait for some time so that the infection settles down, and then later on tackle this stone. But sometimes, yes, these cases are we do come across such cases.
Yes. And that point of time, when the patient suddenly becomes unstable, like tachycardic, hypotensive, that time you have to have that diagnosis, differential diagnosis in your mind. Otherwise, you will start wondering what has happened to the patient. So that's why it's very, very important to keep this diagnosis in mind, and patients who have very tight or very big stone.
Absolutely.
Yeah. Thank you, sir. Thank you. Thank you.
Sir, there is okay, we'll just cover one more question for Atul, sir. So, Dr. Smita Rao is asking in obstructing calculus, if patient is relatively stable, would you still do DJ stent or go ahead straight away with PCNL?
Well, it all depends whether there is any infection. At any moment, if I am thinking that there would be some amount of infection in the pelvic system, I would first put in a DJ stent, wait for the infection to settle down, and then proceed with the surgery. But yes, if there are no signs of any infection, the patient has been there stable for quite some time, then we can proceed with the directly with PCNL or with the tackling the stone with due care of intrarenal pressure. Because as Madam Parna also pointed out, the intrarenal pressures and bacteremia, septicemia, these are the dreaded complications which we should try and avoid.
Okay. Okay, sir.
Basic
There's
idea
one
is to
more question.
keep nephrologist away. Basic idea of immediate intervention is to keep nephrologist and an intensivist away.
No way. No,
Sir, next,
without
there,
nephrologist backup, we cannot proceed.
Oh, no.
next, I think next question is for you. Anyway, so we'll move on to the next session. I think this next question about serum creatinine levels over 7 to 8 and role of preoperative dialysis is question for the next speaker. So
Want me to
I'll
answer that
proceed.
first?
No,
You want me to answer that first?
no, it's okay. I think we should cover your lecture first. So, as
Okay.
anesthesiologists, we proudly call ourselves the perioperative physician. But when dealing with high risk cases, it is nice to have a super specialist physician in our corner, especially when the physician is as approachable as Dr. Gunju, who has almost 40 years of experience in nephrology alone. He received all of his medical degrees, that is MBBS, MD, and DMB nephrology from KEM Mumbai. He is attached to various hospitals in Thane, and he is here to talk about medical management of obstructive uropathy. Over to you, sir.
Thank you, Mrunalini. First of all, I must thank the anesthesia group of Thane for inviting me here to give a talk on a very, very important subject. I think Ashwini and Atul have covered most of the things. Ashwini has answered all your questions about anesthesia, which anesthesia, what anesthesia, and Dr. Atul has described all procedures in so many details that anybody who listens to this would feel that he should have a stone, and then they should go to Atul and his wife. So thanks a lot for inviting me here. We are going to discuss And my tributes to all anesthesiologists, because they are somebody who can make patient sit, they can make patient breathe, they can make patient sleep, they can make patient get up whenever they want. So trying to make the patient comfortable for a surgeon. So all my tributes to all anesthetists, not only because Mrinalini is my daughter-in-law. Let me start sharing my slides. So I'm poor at all these things. So let's see.
Hello.
Hello.
हाँ
एक
सर.
मिनट.
Yes, yes, yes. Visible है sir.
Okay. So basically, we are going to deal today with obstructive uropathy, which most of the times it is a stone, which Dr. Ashwini and Atul have dealt with. But there are many more causes for obstructive uropathy, and which they need to be dealt with very seriously and as quickly as possible. Not moving. Yes, it is common in day-to-day practice and needs to be handled as an emergency or a semi-emergency. In acute phases, I think Ashwini has described quite a few acute septic cases where immediate double-G stenting was required. There are some non-emergent situations where some quick interventions are required to prevent progression to chronic kidney disease and end-stage renal disease. And anesthesiologists play a very important role in all these interventions that Dr. Atul has described. The interventions for other obstructive uropathy or nephropathy are more or less similar to what is being done for the stones. There are some definitions which we must know. The hydronephrosis means dilatation of renal pelvis and the calyces proximal to point of obstruction, whereas obstructive uropathy means blockage of urinary flow due to functional. Very important to realize that there can be functional causes and the structural derangements anywhere from tip of urethra back to renal pelvis with resultant back pressure. Obstructive nephropathy, on the other hand, is when a nephrologist needs to be involved, the functional or pathological damage to renal parenchyma because of obstruction to the renal obstruction to flow of urine. This is the anatomy of the kidney. We are blessed with two kidneys on one kidney on each side. There are some unfortunate people who have only one kidney. Sometimes the kidney is in the pelvis. Sometimes the kidney is placed on the other side. Sometimes both kidneys are low. So all those things are there in congenital anomalies. So we are fortunate to have two kidneys, and one kidney is sufficient to have maintained life properly. So this is the from the kidney down to ureter and to bladder and urethra. That is what is the normal flow of urine. So these are types of obstruction which calculi have been described extensively. There is important thing that there is something called pelvic junction obstruction, which usually is congenital, and it is there since life, but it does not manifest very early. It can manifest anytime after 30 years of age or 20 years of age. The second important factor to remember is posterior urethral valves, which are there, and unless they are tackled very early, and vesicourethral reflux, ureteral reflux, these need to be tackled early in life to prevent progression to chronic kidney disease. Some of these causes of obstruction, which are most of them are calculi, strictures, stenosis, the tumors, external pressure from lymphomas, retroperitoneal fibrosis, all those causes we must know. Why it is important to know the cause of obstructive uropathy is obviously what procedure is planned, how early it is to be planned, how it is to be planned by urologist and by Ashwini, anesthetist like you. They will need to know what exactly anesthesia is required. So some important congenital causes are pelvic junction obstruction. These manifest maybe in later life, because patients will keep on asking you in younger age group why this was not picked up early, why this was not done, why that was not done. Similarly, neurogenic bladder is one more important cause of obstruction because it produces refluxes. In adult population, there are so many causes. I don't think we need to go into that because the ultimate treatment required is to relieve the obstruction and prevent the further damage to the kidneys. Very important, side by side, important is some medicines which can cause the intracrystalluria distal in the tubules, and that causes the renal failure. Very important drug which is commonly used is acyclovir because nowadays the herpes has become fairly common and it is very easy for somebody to say acyclovir chalu karo without really knowing what is the underlying renal function, and these the patients present with acute kidney injury. There are other causes like papillary necrosis, which are very obvious many times because it produces pain and hematuria, and the diagnosis becomes easier. Anyway, any cases where there are symptoms, the diagnosis is picked up early, and the interventions are generally patients will agree for interventions faster. So therefore, something like stone, which is painless. Some stones are painless, and he has shown you so many good pictures of stones, which are stag-on stones, which keep on growing inside without being known. And ultimately, when the chronic kidney disease sets in, you realize that it is because of these stones. So whenever there is pain or whenever there is bleeding, these things are picked up early and treated early. These are some of the causes. Very important cause is CA prostate, which is easily treatable, where it can produce distal obstruction, bladder outlet obstruction, and acute kidney injury. Very difficult to convince the patient for further management. You put in a catheter and everything really improves, but many times these patients do not follow properly and do not take proper treatment. Retroperitoneal masses, retroperitoneal fibrosis. I have a patient who is on bilateral ureteric catheter almost for 5 years now for retroperitoneal fibrosis. His presentation was very interesting because he came with creatinine of 2. Sonography showed mild PC system dilatation, which we would have actually ignored. But within 2 days' time, his creatinine shot up to 6, and the CT scan showed retroperitoneal fibrosis. So we did percutaneous, we did bilateral stenting, and we are recurrently it, and he is still his creatinine is 1.1. So these are some of the issues which have to be initially assessed and tackled. The pathophysiology is fairly simple to understand. There is blockage of the system, and therefore there is like what everybody has been saying, increase in the intrarenal pressure, back pressure, initially there is increase in the renal blood flow. Initially they try to increase the GFR, but over a period of time, due to various internal changes, internal hormonal changes, and various molecules are secreted, growth factors, all those result into the obstruction and and reduced GFR. So therefore, it is important to pick up obstructive uropathy very early and do necessary measures. This is the morphology: mild, moderate, and severe dilatation, like what you can see the last one, where the kidney is swollen and it has become very thin. And when you do a sonography, sonologist will report thin papery parenchyma. So this is the presentation, which is very late. This is the hydronephrosis, which all anesthetists must have seen during the surgery, how it looks. The presentation is varied. There are some patients who will present with acute abdomen also, where this management, I will present a case little later, which is more or less presentation, but in a different way. There was a question where the patient with 7 and 8 creatinine, many times these obstructions are partial or it is unilateral, so that the other kidney functions well, and these things are not picked up very early. Like what I said, important is all painful things are picked up early, whether it is in kidney, whether it is in heart, or anywhere else. So whenever there is pain, the patient will get himself investigated and come with the proper diagnosis. So acute obstructions, many times patients will come with some difficulty in passing urine, hematuria, dysuria, frequency of micturition. Some patients will come with suprapubic pain, and you just examine them and you will find that they have bladder palpable up to umbilicus. So these things have happened, and you need to examine a patient properly, because one patient came last 2 weeks back with lot of pain and lot of discomfort, and he said, I have not passed urine for 2 days. So I was shocked, because he was around 83-year-old. I thought he was in total anuria. In my mind, I kept on thinking what must have produced it. I just happened to examine him, and the umbilicus was up to bladder. So of course his creatinine was normal, and after catheterization he improved. So the obstruction can be unilateral, it can be partial, it can be total. Very important to remember is single functioning kidney with obstruction. Many times the patient is not aware that he has got a single functioning kidney. The other kidney is small, or maybe it is absent, and the patient comes with anuria, and you don't know what to do. In these situations, it is very important to do immediate assessment and take the patient for DJ stenting. In chronic cases, of course, the varied presentations are there. I need not go into those chronic presentations. How do you evaluate a patient with obstructive uropathy? First of all, you must know renal profile, whether his kidney function is normal, what is the electrolytes, what is acid-base balance. Ideally, from anesthesia point of view, you would like to know whether there is any liver function abnormality. Coagulation profile is very important, like Ashwini showed a patient with thrombocytopenia. So before you intervene, you need that. Blood gases, X-ray chest. Very important is X-ray KUB. Many times these KUBs are not done. The urologists are very specific that they want to have the KUBs done. It may show a proper stone. ECG, echocardiography. Ultrasound will show what is the status of the kidney, whether both kidneys are there, whether there is any swelling, whether there is any perinephric standing of or perinephric collection, anywhere, any evidence of obstruction in any part of the urinary tract. Very, very important to screen the patient for post-white residue, because if you just write abdomen pelvis without writing post-white residue, usually your sonologists don't carry out that, and then you have to tell the patient to go and get it done again. This is for relatively chronic cases. For an acute case, you may not be able to do post-white residue. The further investigations depend on CT scan, whether if creatinine is raised, then you have to do CT scan. IVU is possible only when creatinine is normal. In some cases, MRI helps. In some of the chronic cases, you need to do DTP urinogram with Lasix, which shows the assessment of kidney function on either side and the level of obstruction, and whether the obstruction is after relieving the obstruction, whether the patient will be benefited. So that DTP renogram or EC renogram we need to do. This shows functional assessment of the kidney. Then sometimes to come to a diagnosis, you may have to do retrograde pylography. This is not used very commonly these days because diagnostic modalities are fairly advanced. MCU or DRU are required. MCU is required for proving or disproving reflux. DRU is required to rule out urethral stenosis, urethral strictures. So now we come to something what ultimately leads from obstructive uropathy to acute kidney injury. Basically, acute kidney injury is deterioration of renal function in few hours to few days. And obstructive uropathy is one of the most fairly common cause of acute kidney injury, which can be treated very fast and which can prevent patient to go on from going on to dialysis. So these are the initial measures that we need to do. I don't think we need to go into details of how to manage acute kidney injury, but before going on to the further things, there are 4 phases of AKI, which all of us know. There is onset phase or prerenal phase, there is oliguric phase or anuric phase. Then after that, there is diuretic phase, and finally a recovery phase. Usually the onset phase is where the GFR urine output decreases first. After that, the creatinine starts rising. Then with interventions, the patients may start having, if the interventions help, then urine output may improve. This is called as anuric or oliguric phase. in depending on what is the insult, the oliguric unuric phase is about 3 to 4 days, from that to about 21 days. In first 4 to 5 days, you need to decide whether patient will require dialysis, and after the factor which is responsible for AKI is corrected, the patient will get off dialysis and then complete recovery will occur. This is a case that we handled just about 10 days back. This patient actually is a representation of how the things change within few hours or few even 24 hours. This was a 55-year-old female. She was a diabetic. She presented with fever, loose motions, vomiting. The loose motions were watery 10 to 15 times a day. Duration of vomiting and loose motions was about 4 to 5 days. She came to hospital with extreme weakness, drowsiness of 2 days duration, and practically oligonuria for 1 to 2 days. On examination, her pulse was feeble. The pulse rate was about 100 per minute regular. She was tachypneic, blood pressure was 100 systolic. Fortunately, chest was clear. Patient was drowsy with no focal neurological deficit. Abdomen was distended and there was tenderness all over the abdomen. Peristalsis was feeble. So obviously, the initial diagnosis was acute kidney injury because of acute gastroenteritis. So the initial investigation showed hemoglobin of 8.5, total count of 23,000, platelet count was 40,000, which came down to 16,000. Creatinine at that point of time was 4.5. Patient has severe metabolic acidosis, pH was 7.09, bicarbonate was only 4.9. She had severe metabolic acidosis, potassium was 6.2, and further to add to this, her sodium was only 110. So initially, this was thought to be acute gastroenteritis, acute kidney injury with metabolic acidosis with mild volume overload. So we tried to treat her conservatively. The sonography showed right kidney of 12.3 into 4.1, left kidney of 10.6 into 5.9. There was mild left hydronephrosis and hydroureter, grade 1 medical renal disease. She was a diabetic, so medical renal disease we thought was possibility of chronic diabetic nephropathy. Rest of the abdominal organs were normal. At this point of time, we thought that with all these things, she required anyway dialysis. By that time, she had already gone on noradrenaline. So noradrenaline, we used Lasix infusion as well to get some amount of urine, but she hardly passed any urine. She needed dialysis with due risks. We gave her one dialysis. By that time, we had the CT scan done because it showed left hydronephrosis and hydroureter. So there was some underlying issue. We thought that it could have been because of infection. But then the CT scan came as 18.6 millimeter calculus in left upper ureter with thickening of left renal pelvis, perinephric fat standing, and dilate in left upper ureter. This stone was fairly large. Stone was there. There was a stone in the calyx as well, and the right kidney was bulky. So, like what Ashwini had presented, 2 or 3 cases of acute obstruction with sepsis. So this diagnosis turned from acute gastroenteritis to pyelonephritis and pyonephrosis practically. So she was treated with obviously higher antibiotics. Central line was introduced, Lasix infusion or adrenaline. Acidosis was corrected. She required non-invasive ventilator dialysis. And immediately next day, we did her bilateral degestenting. Dr. Atul did it. And she required single donor platelets as well, two units of single donor platelets. With that, her platelets came up to 75,000. Immediately after that, she became she went into diuretic phase, started passing a lot of urine. Creatinine came down from 4.5 to roughly now it is around 2.5. Obviously, we'll need further treatment for the obstructing stones. This is to point out that some investigations may show something, some investigations may not show something. There was a point at when we learned if learning was if a good ultrasound is done, you need not do a CT scan. So many times, whenever Atul used to say or Ajay used to say, do a CT scan, I used to say, "Arey, kya karenge karke." But now we have seen that many stones or obstructive pathologies are not picked up only by sonography. So you need to do a CT scan, preferably with a contrast if it is possible. Otherwise, plain CT scan also makes you more aware of what is happening to a patient. How do we manage obstructive uropathy? So basically, if it is something that is without any problems, you try to do proper hydration, you try to give hydrotherapy, make them after evaluation, obviously. If it is a stone, small stone, you try to do hydrotherapy. You need to maintain proper electrolyte balance. You have to correct metabolic acidosis if it is there. Infection, of course, in all these cases of obstructive uropathy, especially acute cases, they are always infected. And moment you do some instrumentation, they suddenly become worse, like what Parna was asking us that time. So diet in these couple of days, 3 to 4 days, really does not matter. You have to maintain proper fluid and electrolyte balance. Some of these patients who we are not able to get the procedure done very quickly for various reasons. In that case, sometimes like this patient that I presented required dialysis because of multiple things, because she was slightly overloaded, she was hypercatabolic, plus she had sodium was low, potassium was high, she had acidosis. So the dialysis anyway was indicated. In some patients, we can still treat them conservatively and allow the procedure to be done, but ultimately you have to make sure that there is no problem on table. When you ask say somebody to be taken for anesthesia or procedure, you have to make sure that there is no problem on table. You need to anticipate all those problems, because you have seen the multiple positions that are required, multiple anesthesia interventions that are required. All those things are on the face of it looks that it is procedure is only 10 minutes, 5 minutes, but lot of brain goes behind the management, behind all those management anesthetists, the OT team, and obviously the urologist. So some of these things when you are looking at is acid-base balance is very important, where most common problem that we face in any situation is usually metabolic acidosis. Here we have to be very careful that some drug which is patient is already on, whether that is responsible for metabolic acidosis, especially in diabetics, because they may be on metformin. So you need to see that metformin is discontinued, at least if it is a planned surgery, then at least for 2 to 3 days before surgery. So main usually acidosis is corrected by various formulae, but the formula that I use usually is 0.4 into body weight into deficit. So that is the correction. First 24 hours, first 12 hours, I correct half of it, and remaining 12 hours, remaining half of it. So in some cases, there is severe metabolic acidosis. In that case, there are no really guidelines how to really correct it. So we just keep on pushing soda bicarb. And the problem with soda bicarb is many times it can suddenly produce hypocalcemia if there is already hypocalcemia. Uh, Sorry, it is other way around. If you give soda bicarb and calcium is low, calcium will further go down. Similarly, about hypokalemia, when you correct when you give soda bicarb, it reduces potassium. So you need to have calcium and potassium known to you before really you give soda bicarb. But many of the emergencies, all these things cannot be done. Most of the times, the soda bicarb needs to be loaded quickly. The other acid-base disorders is mainly metabolic alkalosis, which is very difficult to treat. It is usually because of low potassium, and it needs to be corrected fairly fast. The other respiratory acidosis, acute respiratory acidosis, I think these are all need to be dealt by the chest physician rather than me. This is a Winter's equation. This shows what do we expect when there is acidosis. This shows that the PCO2, that is CO2 that you see in arterial blood gas or venous blood gas, expected is 1.5 into bicarbonate plus 8 plus minus 2. This is the formula. This gives you the expected PCO2 in a case of metabolic acidosis. If that PCO2 doesn't match in this equation, it says if PCO2 is less than what is expected, then there is additional respiratory alkalosis. And if measured PCO2 is more than the expected, then it indicates that concurrent respiratory acidosis is also present. So these are all multiple combinations of acid-base disorders that can be there in a given patient. Usually, like what I said, I correct with this formula, weight into deficit into 0.4 or 0.6. Usually what textbooks say is should not correct bicarbonate unless the bicarbonate is less than 10 or pH is less than 7.1. I really don't accept it, but this is what the books say. This particularly applies to diabetic ketoacidosis, where you have something to look for correction, like you bring the sugar down, obviously the acidosis gets corrected. One of the most worst situations to be in is hyperkalemia. So these are some things which I think I need to let you know. All of you are very knowledgeable people, so I'm not telling you something that you don't know. I came across this mnemonic, this murder with tall peak T waves. These are the things which are for hyperkalemia, like muscle weakness, urine shows oliguria, anuria, R for respiratory distress, D for decreased cardiac contractility, E for EKG changes, R for reflexes, and which is for widened QRS complex, and T for tall T waves. So this is what the hyperkalemia produces. This is what the ECG will look like in hyperkalemia. And how do you treat hyperkalemia? These are some things which we should know. Intravenous calcium gluconate, glucose insulin drip. Most important is salbutamol nebulizer. You quickly give them salbutamol inhalation. All these measures they put potassium into intravascular compartment. They put potassium out of the intravascular compartment. Same thing is done by soda bicarbonate. The remaining three, like loop diuretics, especially furosemide, and cation action resins, which is available as K-bind or Kexilate, that you can give either orally or you can give it per rectally as well. And obviously, if all these measures are not, the patient doesn't respond, immediate dialysis with low potassium solution is required for hyperkalemia. So after obstructive uropathy, ultimately when you relieve the obstruction, patient, like Ashwini said, they start passing urine very quickly. So after that, there is something called post-obstructive diuresis, where patient keeps on passing urine and it doesn't stop. Means it goes on for 3 days, 4 days, and every time you feel how much more hydration. More you hydrate, more urine comes. So in this period, you need to watch for dehydration. Secondly, you need to watch for hyponatremia, hypokalemia, and metabolic alkalosis. So prognosis of obstructive uropathy treatment depends on what is the site, whether it is complete, whether it is acute or chronic. So generally, if it is diagnosed early and if it is acute phase, in general, the response is very quick and recovery occurs faster. In a patient with chronic obstruction, it is basically our idea is to relieve the obstruction to prevent further progression to chronic kidney disease and end-stage renal disease. So considerations from anesthesia point of view, I think Ashwini has dealt with it, so I'll just briefly touch it. You need to determine urgency of intervention. That it depends on the close association between the nephrologist, urologist, intensivist, treating consultant. Urologist needs to decide fitness. Urologist will need anesthetist to decide fitness from their point of view, and it has to be a very quick communication, and you need to decide when to operate. Type of anesthesia, Ashwini has already told you so many options that are there with them. Earliest possible intervention is the key. You maintain hydration, you need to look for renal dysfunction. Very important is volume status, because for any procedure you need different uh, positions because if the patient is overloaded, then he may not be able to lie down in proper position. So you need to have volume status known. Electrolyte acidosis obviously has to be known. The cardiac status, because unless you know the cardiac status, hepatic dysfunction, coagulation profile are very important. And very important is calcium, because you try to do any intervention with correction of acidosis or what, it may produce problems. Some of the killers in any AKI or chronic kidney disease is combination of acidosis, hyperkalemia, and volume overload. If this combination exists, then you have no other option but to start them on dialysis. But there is one caution: severe metabolic acidosis, one line of treatment is dialysis. But in my opinion, dialysis makes it worse, because the moment they drop their pressure, acidosis is going to get worse. So on one hand, the literature says if acidosis is refractory, you should dialyze them. But in practice, it's not very easy. Obviously, any intervention may lead to hypotension, sepsis. So you need to, like what Atul said, you need to have them covered under proper anesthesia, proper antibiotics before a procedure is planned. So a good coordination between United Nations Assembly is required. U is for urologist, N is for nephrologist, A is for anesthetist. So this is what I would say. And it ultimately depends on basically the skills of the team. And skill of anesthetist, I would still say that skill of anesthetist and the urologist doing the procedure is the most important factor, because all of us will say ye karo wo karo, but ultimate procedure is to be planned and is to be done by anesthetist and urologist. And early intervention for any obstruction, early intervention is always a key. At the same time, you need to look at whether the patient needs that intervention at that particular time. Especially in chronic cases, it may turn out to be a difficult decision when to really go in and do certain procedures. So like what I said initially also, you need to keep a nephrologist away when there is obstructive uropathy. Thank you. These are some of the drugs before you think of anesthesia that you should have evaluated the patient for, whether the patient was on NSAIDs or COX-2 inhibitors, especially radio contrast agents, because in all urological procedures, you would require a contrast CT or some procedure. In that case, the contrast nephropathy increases by third day and then progresses till seventh day and then improves. So multiple contrast injections are also not good, especially in a patient who is diabetic or already has chronic kidney disease, or is specifically in a patient with multiple myeloma. ACE inhibitors, angiotensin receptor blockers, these are important because they may produce hypotension during anesthesia, hyperkalemia, and sometimes acute kidney injury as well. Metformin, like what I said, and I would still stress role of acetazolamide, because previously many times with cataract surgeries, this was prescribed, and some patients with borderline chronic kidney disease came back with severe acidosis. So you have to be careful. Nowadays, it is not used very commonly at all. And one word of caution for SGLT2 inhibitors, anti-diabetic drugs, especially before anesthesia. I read the literature. I was not aware, but it should be stopped 2 to 3 days before any procedure is undertaken. Metformin obviously needs to be stopped at least because of risk of producing acidosis. So, but this depends on the treating physician, how they weigh the pros and cons of stopping. Thank you very much.
Thank you, sir. Very comprehensive lecture.
Thank you.
There are no questions in the chat box as of now. So I just had a small question of my own where you talked about the patient with bladder over distension, where his bladder was reaching the umbilicus. So do you prefer doing a gradual bladder drainage to reduce the risk of decompression hematuria?
Yeah, you have to do that. There is no question, because you put in a catheter, immediately urine comes out. the bladder contracts and suddenly after 2 hours you find that there is clot retention, severe hematuria. It can happen. So because usually over distended bladder is overvascular also. So that is how it can happen. So always it should be a slow drainage. What I normally do is I'm not sure whether I'm right, but what I do is put in a catheter but allow the urine bag at least at a little height so that the drainage is very slow. So Atul can tell us more about it. But of course, it should be a slow drainage if it is a chronic obstruction, chronic overloaded bladder. In an acute retention, you may need not do that.
Okay. Okay. Thank you, sir. There was one question for Dr. Ashwini. Dr. Panna Thakkar has asked, Madam, do you use LMA for RIRS?
Actually, I don't use LMA for RIRS, but you can use LMA for RIRS. Only the requirement is that the tidal volume and the ventilation should be a little less so that the calculus should not move during laser fragmentation.
So even if LMA is used, then you'll have to give muscle relaxants,
yes,
obviously.
we will have to
So
give
you have to control the
the respiration of the patient.
Yeah. Okay. Thank you, ma'am. Thank you, everyone.
There was a question
Dr.
about
Parna, ma'am, you'll take
chronic obstruction. You wanted to ask Atul, I think.
which one?
Chronic
I think
obstruction, tone with raised creatinine. Just
that
before
one.
I start.
If patients have serum creatinine levels of over 7 to 8 in such patients in obstructive uropathy, is there any role of preoperative dialysis?
Theoretically, yes, and practically no, because it depends on what you expect in that patient, particularly if some intervention is to be done. What do you expect maybe in 24 hours or next 48 hours? If there are any clear indications for dialysis like acidosis, volume overload, pericarditis, or uremic encephalopathy, or your judgment tells you that this is likely to happen in next few days, in that case, you would dialyze them first and then subject for the procedure. The most important part where high creatinine is there, you would never know, even if you have done the coagulation profile and everything, but platelet dysfunction cannot be corrected. So even if platelets are normal, they may be dysfunctional. So there are chances of bleeding are there. So one theory is that you must dialyze them, make them good, and then do the procedure. But in such situations, you never know whether they will completely depend on dialysis later on or not. So I would do both ways. Some patients may require dialysis, some patients may not require dialysis.
So Dr. Anjali Patil is asking what is the allowed level of creatinine in patients with DM or hypertension in planned surgeries before starting any treatment?
There is nothing like creatinine. It is basically depends on the other factors, whether there is any additional factor like acidosis, volume overload, hyperkalemia, any electrolyte dysfunction, whether the patient is oliguric, what is the volume status, what is cardiac status. All those things will go into decision whether a certain patient can be posted for any surgery safely without any problems. Depends on what kind of anesthesia needs to be done, what is the procedure, how long is going to be the procedure. So all these things go into the decision whether what level of creatinine you would say you operate. So it depends on many factors. It cannot be only just said at certain level of creatinine you should not operate. But you will have to be careful at creatinine. You will have to be very careful at higher creatinine as well. So depends on how urgent is the surgery, how emergency is the surgery. So in some patients with creatinine of 3 and all other parameters are normal, but surgery is essential in that particular, say 6 hours, 8 hours. I would say go ahead and do the surgery. After that, we'll see how the things go. All parameters should be under control. Then you can probably permit a surgery. The only creatinine level doesn't decide.
Okay. Okay. Thank you, everyone. Dr. Shamini, okay, there is one more question. What is the plan of management in pregnant patient with renal disease?
Depends on at what stage it is detected, whether first trimester, second trimester, third trimester. See, first trimester, if the patient is already known to have some renal dysfunction, then what is the level of dysfunction? Whether there is hypertension at that particular time, whether the renal disease is progressive. In that case, we would ask the patient to get terminated, because as the pregnancy advances, the renal dysfunction will deteriorate, and then she will have problems towards fourth, say second trimester or third trimester. So it's first trimester, basically it's difficult to decide. During second trimester, if she has already carried on to second trimester, then you will have to monitor her very closely, regularly, and then especially in these situations, you will have to have the patient, the family counsel very very clearly that first priority of a treating gynecologist or nephrologist or a physician is mother. So moment we feel that there is danger to mother's life, naturally the things will change accordingly. But there are patients where patients have undergone dialysis during pregnancy, they have temporarily, then they have gone to full term. All those things can happen, but all these decisions depend. You cannot make a certain statement like this. So but generally what happens is, usually a pre-existing disease is known. Then in that case, you know how these things are going to get progress. I mean, how the renal disease is going to progress during pregnancy. If it is detected late in the pregnancy, in that case, these things become easier, because you need to carry them out till the fetus is at least salvageable. Otherwise, if there is a danger to the life of the mother, then you need to terminate any stage of pregnancy. But generally, if they pull on till 28 weeks, it is easier to manage. The problem is superimposed preeclampsia and eclampsia. Both are very bad emergencies. So you need to counsel that if you can try to continue, then the risk to the mother and the baby, both are there. And obviously, you need to worry about any postpartum issues. Pregnancy issues are always difficult to deal with legally as well. So you need to decide based on what is the situation. Not that a patient with renal dysfunction cannot get pregnant, not that way, but the risks are always much higher than what they are for a normal lady.
Okay. Thank you, sir. Uh, Dr. Pranna, are you taking over? Hello?
Yeah.
Where is
Dr.
your-
Manisha,
Yeah,
Manisha or Dr. Nilima will say.
Thank you, Parma. Dr. Katkade is here, so I think he has something to say to us. So,
Oh, nice cat.
494. Sorry.
Fun fact, Dr. Gunjotikar is a cat person.
she was also listening to sir. Sir. Sir.
Yes. Hello.
Okay. 1 minute, sir. I will open it. 1 minute. 1 minute. Actually, you have to unmute yourself, sir. Nobody else can do it. 1 minute. So Dr. Katkade just called up. He is driving and he's not able to unmute yourself, but he has complimented everybody on the excellent webinar. And thank you all for joining in.
Thanks a lot.
Ganesh, can you unmute Dr. Katkade? Sir, you should be able to unmute yourself now.
Sir, click on OK.
1 minute, sir. 1 minute now. Okay. He's in driving mode, so he's not able to communicate. But thank you, sir. Thank you for your, yeah. I think that was a wonderful session. And now we'll proceed with the vote of thanks by Dr. Shamini. Parna, you want to say something?
Yeah, it was an excellent webinar and very simplified and it was application based. I think all of us we practice anesthesia for urological procedures, and it was presented in a very nice pattern. So thank you all.
Thank you.
Shamini.
Yeah, it was a pleasure indeed for Thane ISA to conduct this very interesting and informative session in association with SAMS. And we really enjoyed putting this together. So the whole process was fun. Considering the vastness of uro-anesthesia, we are planning a second session sometime in the near future. So we would like to thank the office bearers of the Society of Anesthesiologists, Maharashtra State, Dr. Balaji Asegaonkar, Dr. Rajesh Tagarpale, Dr. Avinash Bhosle, Dr. Anita Nehete, Dr. Vikas Karni, and Dr. Parna Thakkar. And the office bearers of Thane ISA, Dr. Katkade, who is our GC member and past president, as well as the chairperson today. Our dynamic president, Dr. Manisha Ghosh, our charismatic secretary, Dr. Parna Thakkar, and Dr. Nilima Kelkar, a charming treasurer, and of course the esteemed speakers, Dr. Atul and Ashwini Mukashi and Dr. Rajendra Gunjotikar. So it's put together very well by a young and enthusiastic moderator, Dr. Mrinalini Vani. And thanks to our MMC observer, Dr. Varsha Vyas Madam. And all this was possible only with the constant support from Mr. Ganesh from Jenica Technologies. And last but not the least, thanks to the audience for their active participation.
And thank you, Shamini. Shamini has been instrumental in putting this webinar together.
Yes,
and
yes.
I think it was a real treat for all of us. Thank you, Shamini.
Thank you.
And part 2, definitely, I think we should definitely have a part 2 where we talk about CKD and transplant and all that.
Yeah.
Yeah. And before we depart, once more, a reminder to everybody for the upcoming elections and to exercise their vote. And this webinar was also very unique because at Thane Anesthesia Society, we consider ourselves a family. And today we had actually a family affair with a nice, charming couple of Atul and Ashwini and a father-in-law and daughter-in-law combination, which I think is the first for any webinar anywhere. So well done to all of us. And good night.
Thank you.
Thank you, ma'am.
Thank you and good night, everybody.
Yes, good night.
Thank you. Thank you. Good night.
Bye-bye.
Good night.
Bye.
Bye. Bye. Thank you. Thank you.
Thank you.
Bye. Bye.
मॅडम मीटिंग एंड करू का?
हो एंड कर गणेश आणि युट्यूब वर येईल ना ही आपल्या वेबसाईट वर जाईल ना MSISC च्या
येस येस
ओके युट्यूब लिंक असेल मी पाठवली आहे थँक्यू व्हेरी मच गणेश फक्त काही
वेलकम मॅडम
एक दोन तीन आले कंप्लेंट्स त्यांचं नाव मला रजिस्ट्रेशन लिस्ट मध्ये दिसतंय पण ईमेल आला नाही असं त्यांचं चाललं होतं
मॅडम
सॉर्ट आउट करू ते नेक्स्ट टाइम
त्यांनी ईमेल ऍड्रेस चुकीचा टाकला असेल
काय माहिती रे आय डोंट नो बट विल सॉर्ट इट आउट नेक्स्ट टाइम हा
ओके मॅडम ओके
चल थँक्यू गणेश थँक्यू
वेलकम
बाय
मॅडम
बाय अश्विनी वेल डन आय एम सो हॅपी नाही करत